Good afternoon and welcome to Marrying Patient Engagement and Population Health, a complimentary webinar from healthsystemcio.com. Just some housekeeping before we get started today. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I'll be your moderator today. We encourage you to ask questions. You can type them into the Q&A box at any time in the lower right-hand corner of your screen. Leave the default set to all panelists. We'll be holding those and posing them to our speaker later in the program. You can download the deck at any time using the URL on your screen. There's a shortened URL at the bottom of each slide, and I'll also send it out in the chat box. And we are recording today's event, so there will be an archive available, usually within 2 business days, if not sooner. You'll get an email when it's ready, and a separate registration is required. Just so you see how we're going to spend our time today, we're going to go about 40 minutes. First, we're going to hear from Tom Pacek, VP and CIO at Inspira Health Network, and then we're going to have a approximate 10-minute Q&A with Tom. So without further delay, I want to turn it over to Tom Pacek. Tom, thanks for joining us.
Thank you, Anthony. I appreciate it, and I look forward to a good webinar. Please feel free to ask questions along the way, and we'll address them at the end. Patient engagement. So we're here to talk about marrying patient engagement with population health. I'm sure everybody is on the line is doing some form of patient engagement now and or engagement in population health. So we're going to talk about how we do it here at Inspira, some of the things that we're doing today to engage our patients and marry it together with our population health initiatives. So, patient engagement here at Inspira, our brand strategy is one reason we do patient engagement. We do a lot of work around brand strategy. We've got a merger, in fact, of South Jersey Healthcare and Underwood Memorial Hospital back in November of 2013. So that's what created Inspira Health Network. And so we have a lot of brand initiatives related to our brand strategy, just so people understand who we are and the population we serve and what we bring to the community as far as healthcare. So we do a lot about that. So patient engagement is really important to us from a brand strategy perspective. From a meaningful use perspective, I think we all know that it's critical. If you're going to do stage 2, you have to engage in patient engagement for meaningful use for stage 2, and stage 3 is just packed with opportunities to engage with our patients in order to meet stage 3 proposed requirements as they stand today. So meaningful use is obviously another reason why we do patient engagement here. And the last but not least, population health. And population health, allowing us to manage our specific populations, and it gives us the opportunity to engage with our patients in a much closer way and a more interactive way, and we'll talk about that a little more as we go through the presentation. But, if you do this right, if you do the population health piece right, and really engage your patients in population health, then, you should be able to achieve better outcomes and hopefully, and we're counting on it, bend the cost curve in a positive way for us. I'm trying to move on to the next slide. Anthony, can you slide that
for
down?
You, Tom?
Yeah, please.
There you go.
Sorry.
You just got
Sorry.
it. That's okay.
Sorry for the delay. So where does engagement begin? With us, it really begins anywhere, and for you, for that matter, anywhere your brand is seen. So engagement starts, with our TV ads, for instance. We have a huge marketing campaign. A lot of it's TV-based advertising. We do advertising on the internet. We do advertising on billboards, your physician offices. If you're not taking advantage of your own physician practices and advertising your brand in those offices, you should be. there's a huge opportunity there. Your facilities, all your facilities, so your hospitals, if you have long-term care facilities or you have surgery centers, we have a lot of imaging centers and dialysis centers in the ambulatory space. We also have some urgent care centers. So all our facilities have Inspira brand strategies going on in them, as well as information about how patients can connect with any of the services across Inspira. Even though they might be in urgent care, they can learn about the hospital services or imaging services or any of the other Inspira services from any of these forums. And of course, in the patient's home. So our home health agency goes into the patient's homes, our EMTs go into patients' homes, and that's another way for us to get the Inspira brand out to the patients and start engaging them with Inspira Health Network. So when does engagement stick? So we talked about the where and how you start the engagement process, but how do you make it stick? So anywhere where you come in contact with a patient is our philosophy here. If you got a patient in front of you, you have an opportunity to make an impression on that patient and get them engaged with your health system. So we do that at points of registration. Very much so at points of registration. We offer the opportunity for them to sign up for our patient portal at registration to help engage them even further, to let them see their lab results and their radiology results. So every registration point of entry, so hospital, outpatient, all the imaging and dialysis centers we talked about, the urgent care centers, our physician offices all have information and can help a patient sign up for our patient portal and get involved with Inspira Health Network in that way. At the patient's bedside, we do the same thing. Because of meaningful use, we actually went to the patient's bedside and engaged with the patient at the bedside, asking them if they'd like to sign up for their patient portal, would they like to see their results available to them. We have done that very successfully, and we've continued that. Even though we did a test already for stage 2, we continue to do that for the next phase of stage 2, reporting and attestation. So we do have people that go visit patients, and it gives them the opportunity to do training as well and educate the patient on how to get into the patient portal, how to access that, and give them the opportunity to ask questions and be educated. We have the opportunity at our website to do the same thing, to engage in the patients, show meaningful information on that website that's engaging to the patient. We give them the opportunity from the website as well to sign up for the patient portal. At your call center, if you have a call center, most organizations do, but if you do have a call center, you should be taking advantage of that as well to be able to market to the patient, to make sure that they are aware of all the different services that you have in your organization to help them possibly sign up for your patient portal as well. And it's another opportunity to learn. One of the things we're not doing at our call center yet, but will be in the not-too-distant future, is being able to take that and share things with the patient back and forth as far as screens and things like that. So you'll be able to actually help a patient through the signing up on your patient portal, or if they're in your patient portal and they're having a problem, you could be the possibility of remoting into their computer and helping them through that process and doing some hand-holding and education that way. And again, the same thing at the patient's homes. Our home health agency, our home health nurses have the capability of doing that and engaging with the patient, helping them sign up for the patient portal, and engaging them in that way. Now that you got them, how do you keep them? So your patient engagement requires a significant amount of focus on retention. So once you have them, so there's definitely focus on the front end to get them engaged. But once you have them engaged, how do you keep them? How do you get them to stay within your health system and not go somewhere else? So you got to bring them value. For instance, our patient portal today, or initially, gave them information about their lab results, their radiology results. Well, okay, that's value to the patient. However, if you don't have any tests done, there's no reason to go there. So you've lost the attention of the patient. You only have them there for that brief moment when they're looking up a result. So our job in information technology is to try to figure out how to drive more value to the patient, how to keep them engaged. What else can we be doing to drive them electronically to do business with us, let alone physically doing business with us. So drive that interaction. It's really, really important to drive interaction with the patient. We do that. One of the things we're doing with interaction is bringing out a set of mobile applications. So we've just launched a My Inspira application. It's in the Google Store. It's in the Apple as well, the Android Store and the Apple Store. And so we launched that last month. We actually followed that up with some marketing information because we actually, our latest TV ad is actually marketing that particular application and trying to make sure people understand it's easy to access us, it's easy to do business with us. And so it drives some interaction. It gives the patients the ability to be able to not only get things pushed to them, which is great. It's one step better than just a static web page where they go see results. We can push information actively to them, but they can actually interact with the information, and they can interact. There's the ability for them to message back and forth between care teams and themselves. And so the application does a whole lot more than just pushing things, but it actually drives interaction as well. And again, making it whenever possible, if you can make it personal to that patient, specific to maybe they're part of your disease population, your diabetic population, your CHF population. Maybe they're using your health plan. Maybe it's an employee that's using your health plan, and you want to make sure that you make that as personal as possible. That is more of a futuristic stuff for us. I mean, we're doing it as much as we possibly can, but I think what we'll see here at Inspira is things will become more and more driven on a personal basis to the patient as we go forward. As technology evolves, as new applications and functionality becomes available, we'll be putting a stamp on personalization. So Pop Health, how do we make it stick? We maximize the opportunity to make this thing stick, to engage. So Pop Health does that for us. We see, again, as I talked about earlier, Pop Health is really the opportunity to engage the patient in their care. So if you can't make that successful, I don't know how else you get a patient engaged, because this is the bread and butter going forward. You got a patient in front of you, and you need to be able to provide opportunities for them to stay with you, to get involved in their care, and really become an active participant in preventive care, proactive, or even reactive care if they haven't been proactive in the past, but they've come down with an illness. To get them involved in as you help them through that illness and then on the road to recovery and then keeping them healthy going forward. So you have these opportunities, and here are the different areas that we focus our attention on from a Pop Health perspective. So from a physician's office or our urgent care visits, we absolutely want to engage in with Pop Health. We give them the opportunity in the physician's office to not only engage with the physician, but, schedule follow-up visits, have that physician office information go into their patient record. Urgent care visits, the same information would be available for the patient as well. So I'm going to go through each of these individually. Let me just move on to the next slide. So from the physician's office, ability to have history and treat the entire patient, not just the current problem. That some would say that's probably one of the definitions of population health or care management, is really treating that patient for their entire person, not just the current problem they're in front of you of. They may be coming in for chest pain, but guess what? They're also a diabetic, and so you want to be able to treat them and make sure you're aware of the other conditions they have, and be able to treat that whole person, and not just the current problem that they're dealing with. So having the ability to schedule appointments right then and there. So having a physician be able to schedule an appointment, let's say they're referring you to a cardiologist for follow-up, to be able to do that right there in that physician's office at that time just makes that a much more pleasurable experience for the patient. It makes it easier for them if they know their schedule, that you can do that right then and there. They don't have to go contacting that physician's office. If you link all that stuff together through data and your networks, our HIE, you have the ability to do things like that and allow scheduling of appointments electronically. Ordering tests, allowing our physician offices to order tests that are done either on an outpatient basis here from the health system. So allowing them to do that right within their EMR, send that order over, send the results back to them without having to pick up a phone and do that or have the patient have to do that on their own. Makes things a lot more easy, a lot easier, and really helps coordinate the care and close the loop, the testing loop, and the ordering process. The ability to share results electronically, I think everybody has that kind of capability now, but we want to continue to do that from every point of entry. So from the physician office, urgent care center, ERs, all those, you want to be able to share any of the information, the notes that are happening on that patient visit. If you can share those notes back into the patient's personal health record or with the consulting physician or referring physician going forward. You also have the ability to educate. In every one of these instances, you have the ability to educate the patient. Again, on other services you have, or educate them on how to better manage their care, their disease, if they happen to have a disease state. And the ability for us to manage compliance and outcomes. So that's really, really important for us to be able to stay on top of the patients. If we've asked them to do something as part of the care plan, as part of their responsibility, that we have the ability to somehow monitor that and make sure that they've actually followed through and did that. And so we all come out with the right outcomes. The patient has a good outcome, and obviously we have good outcomes and results. Emergency room and hospital bed, we have the ability to identify, again, the patient. So when the patient comes into the emergency room in the day and age now of managing populations, we need to know that. The primary care doc needs to know that. Maybe they're part of a bundled payment for a CHF patient. We need to make sure that the cardiologists know that. Their practice needs to know that. The care management team needs to know that. So identifying patients when they hit the emergency room sounds simple enough. We are doing that, but there's a lot of people that aren't or don't have the capability of electronically notifying people that a patient of theirs, a physician's patient, has come into your emergency room. And the timeliness of that information is critical going forward in the population health world. Same thing with the hospital beds. When the patients hit your hospital bed, you want to be able to notify the physician. You want to start involving the care management team, who will also engage with the primary care office based on discharge, so that you're involving your case management in the hospital, who's also involving your care management team. So once the patient's discharged, the care management team, if they're part of one of your patient populations, can follow up with that patient, can follow up with the primary care doc. A lot of this is happening electronically, so the communication is done via messaging, or they're picking up the phone and calling as well. Ability to triage based on current and past history, all that stuff. The patient doesn't have to tell you this stuff because you have the information. If you're doing this electronically and you're sharing the information, and the patient's consent is to share the information, the patient's noticing the fact that they don't have to be repeating all this information again. And they're showing up at a doctor's office post-discharge, and the doctor already knows what they were supposed to be, what they were discharged with, what the instructions were. And when you go and present yourself to a patient care, your primary care doc, and they have all that information already, it makes a huge impression on the patient, that we're coordinating that care, that we're involved, we know what's going on, and we're following up with them and having their best interest at heart. Let's see, home visits, same thing. We do the same thing with home care. We have the ability to pull up the patient's history when we're visiting the patient. We have their latest lab information, so it's really important when we're visiting patients that we have the capability of doing those types of things. Again, it makes an impression on the patient. You're not there asking them, hey, did you get your lab results back? We're sharing information with the patients because we have it available to us. If they have their personal health record, they should have the information as well, but we're reinforcing that with our technology and our people. So the ability to coordinate, so when you're in a home care visit now, we have some capabilities now through secure messaging, a secure communication tool that we have, and I'll talk about that in a few minutes, where they can actually instant message with a primary care doc as they're making that patient's visit. So they're in front of the patient, patient's got a question, the home care provider doesn't know the answer, says, you know, we got to talk to your physician, before they would have to reach out to the physician afterwards, get back to the patient, or have the doctor get back to the patient. Now you could do that real time. You can actually enter into a three-way conversation with the patient in front of you and be able to get the answers. Again, you got to figure that out through workflow and work with your primary care docs to make that a smooth transition. But the technology exists, and the ability to satisfy the patients and engage the patients more is greater if you have those kinds of capabilities. Let's see, I'm going to just, for timing's sake here, virtual visits. So this is something that we're not doing yet, but this is a future that we want to be adding to our capabilities. So the ability from our mobile app to actually engage with a patient for a virtual visit. So some would call it telemedicine. It's just a face-to-face, like a FaceTime type, but it's a secure video consultation with a provider. And so one of the keys is you got to have that patient's information. So again, when they're making that contact with you, you have that patient information in front of you, and you're engaging with them on their care. You already know that. You're kind of impersonal on the other end. You may get your doctor, you may get somebody else, part of the care team, but they have the information about you ready and available to talk to you about. So it makes an impression on the patient for sure. Long-term care, we do the same thing. We collaborate a lot with our long-term care and rehabs. We don't own any, but we do affiliate with many in the area here. We share data through our health information exchange with our long-term care and rehabs. We do hold those relationships in high regard, so we have some standards and quality of care that we expect from them, you know, when we're doing business with them. And so we do have preferred partnerships with them based on their performance, and they should have the same with us. I mean, they should expect certain things from us, and we try to provide a give and take on that with those relationships. So we will recommend facilities to people based on their performance, and help our patients engage with those facilities as well as engage with them, help our patients engage with us. And the last piece is the care management piece, and these are, you know, we have a set of applications to do care management, so to do care plans, to do attribution, to do registries. We have a full suite of products to do that from an application perspective. The care managers themselves are people that use the technology, but they are really engaging with patients specifically around our employee ACO. We have a shared Medicare shared savings program. We also have we're a PCMH, so they engage with patients in those particular ACO type payment arrangements. We also are starting to look at those populations more from a disease management perspective too, and managing the patients with high risk, high severity patients for CHF, in particular diabetes, and so we're working on those. those patients, engaging. Again, these are people that are reaching out to the patients. They also work closely, again, with care management from the acute care side of the business, and they also work with the PCPs that were releasing people back from the hospitals, from the EDs or the acute care environment back to their PCPs. So we're following up on these high-risk patients, not only with the patient themselves, but with the physician, and coordinating care plans with them, and making sure that we're all on the same page on how this patient should be treated, and the patient knows and is engaged in that treatment plan as well. Briefly, I want to just talk about the technologies we're using here to make all this stuff happen. I talked about a secure communication platform. We use that to send alerts and reminders to our physicians. We also send alerts and reminders to our patients, appointment reminders, those types of things. There's secure messaging going on there. Right now, the patients are not secure messaging their physicians, but that will be coming in the near future. The physicians and the nurses are doing a lot of secure messaging through this technology, which has helped us quiet our hospitals, actually. No more overhead paging in the hospitals. Appointments, again, the patients are able to schedule appointments or request appointments through the application. We can do surveys, we can do online forms through this mobile application, provide obviously directions to our facilities, and monitor the compliance. So if we've asked a patient to do something in particular, this is a future coming, but if we've asked them to schedule an appointment, we're going to have that connected to our systems here. So we're looking, 48 hours after discharge, we ask Mrs. Smith to make an appointment with her primary care. If the primary care does not have a scheduled appointment within that period of time, we will send a notice. We will be monitoring that. It'll be alerting us and alerting Mrs. Smith and the care management team to follow up with Mrs. Smith as to why she didn't make her appointment. Other technologies we use is IVR technology. So we do appointment reminders for radiology studies right now. We're going to be expanding that to other studies as well. We use IVR for surveys as well, and various types of data collection. We have a business intelligence platform. We use that to monitor performance not only of all these populations that we're managing, compliance of our patient population, compliance of our physicians following our protocols and our care plans. So we use BI a lot here at Inspira. Again, we look at outcomes, we have dashboards and different types of tools to help everybody understand the data and know what's most important. We have a health information exchange. We talked about that already. We have shared data since 2009 between our practices and our physicians. We have the capability of sharing that with their EMRs, as well as a clinical portal for them to just view information that's in the exchange. The patients have the exact same view. So their personal health records that I have listed there, personal health records, when a patient signs up for our patient portal, they have access, or our mobile application, they have access to their personal health records. That's where we send all the results. So they can see their results, they can see notes, progress notes, things like that. Anything that we allow and expose to them through the health information exchange is available to them in a personal health record. It is the same, again, it's restricted to what we allow the patient to see, but it's the same database that the physicians are looking at when they go into the clinical portal. It's the same physician information the long-term care facilities have access to when they're, ready to receive one of our patients. So it is our be-all and end-all truth, our clinical record available. And again, we control what the patients see in there. And today, obviously, it's results, and we're putting more and more information, or opening up more and more information for the patients to see through there. The real nice thing that we just added recently through that secure communication tool, which is also that the mobile app, the Inspira mobile app, is the patients are now able to request access to their personal health records. So if they've never gone into it before, they can now request it online through the application. They do not have to come into our HIM departments anymore, which was a requirement before. We needed to really know that you are who you are. So that was a tough one. HIM directors will tell you, we really have to know that that's the person requesting it, requesting access. We're giving it to that person. They can now do this. We've linked it up with Experian, a credit bureau, just to do a credit check in the background and make sure that everything's copacetic and we know you are who you are. So that's the most recent thing we've launched on there, and I think in the last 2 weeks we've had over 375 hits to that of people signing up and getting access to their personal health record without HIM involvement. So that was a mouthful. It's a lot of information to try to get done in a 30-minute period of time, but I appreciate you all listening to me, and I think we'll turn it back to Anthony for questions and answers.
Very good. Thank you so much, Tom. Great presentation, a lot of good information, a lot to think about. So as I mentioned to our audience, go ahead and type your questions into the Q&A box. Leave the default set to all panelists, and we'll get those in front of Tom. So we got about 10 minutes for questions. Tom, first question is, what type of usage have you seen so far with the My Inspira app, and do you know if older patients are using it as well?
So I don't have the details because we've only done this for the last, it's been up for about 30 days now with the patients, a little over. We've got over 600 patients up and live on the application. Breakout Apple to Android is a little more Apple than Android, but other than that, I don't have any other statistics to share with you right now. I think it's a little lower than we'd like because our employees should be using it as well, and I'm not sure if we've done as good a job of marketing to our own employees that application. Of course, they see our ads on TV, and I think they're thinking that's for the patients, not for themselves, but that's where we're at so far, but we're really happy about that, them going into their personal health records. I think that number's pretty significant for us.
Well, you touched on an interesting point, the idea of different marketing techniques for employees versus patients. Any more thoughts around that?
So we do a lot of communication to our employees. In fact, our ad was sent, the TV ad was actually sent out via email link to all the employees before it ever hit the TV, so like a day or two in advance, saying, hey, look, this is our new marketing campaign, our new ad out there. We do it at all our directors' meetings. We have employee town hall meetings. So there is a communication plan that's been rolled out with this for the employees as well. Not sure if it's as effective as we want it to be right now, just because we're just not seeing that tick from the employee population. It'll get there. We'll continue to do the push.
Very good. Next question. Did you do a pilot first regarding instant messaging with PCPs? Were the physician offices resistant, and how do you handle that as far as billing hours?
So we did do a pilot. We did a pilot with a couple groups of physicians in the hospital. They agreed to, not be overhead paged. All the communication was going through the instant messaging. We give the offices, each physical office, so if they have 3 offices, then we give each office 2 desktop licenses to do the instant messaging, because there is a cost to us, and we're trying to control the cost somewhat. So we give them 2 licenses. They are concurrent licenses, so they can have the whole office signed up, but only 2 people can be using it simultaneously. It's worked out really well. One of the next phases is allowing them to actually manage their schedule, their own on-call office schedule through the application as well, which will drive them to use the app even more. Adoption's been tremendous. We just went live with that Quiet and Hospital initiative June 2nd. We are averaging a page, one overhead emergency page for maybe a physician that doesn't have a phone that can do texting or something like that. We've basically banned all overhead paging with the exception of an emergency page, and we're averaging 1 emergency page a day over the last 2 weeks. So it's been really successful. The docs have adopted it. Communication's actually been higher. We manually had 150 overhead pages a day on average, and the communications is over 500 a day where there's secure messaging going on back and forth. So the communication's actually gotten better.
Very good. Question, did you get any outside help to drive engagement and or develop your technologies, or was everything done in-house?
So we use outside tools, but as far as outside help, we didn't bring any outside consultants in or anything to help us with a strategy on that. That was all internally done. A lot of that myself, working with the rest of the executive team to decide on what options were out there and what we wanted to pursue. But we don't build any of these things ourselves, so none of this is in-house developed. It's all off-the-shelf products that we use, and we basically stitched them together to deliver the solution to the customers.
Okay. What protocols do you support to enable third-party, so non-Inspira access or provide data to the patient PHR, such as HL7, Blue Button Plus, direct protocols, or others?
So right now we do HL7, we do direct. We do not do Blue Button at the moment, although there's discussion about that. And honestly, I'm going to freeze on some of the other technologies that we use. So there are various other protocols that we do support, and they're escaping me at the moment. But if you want to send me an email about that, I can get you more information.
Okay. We talked a little bit about risk, the issue of risk before we started the call today. Do you see the ability to accept risk as being a key to success in this area?
As far as population health goes, yes, absolutely. And that's been a challenge with our program. I mean, seriously, you're asking a leap of faith of the finance people that are still getting paid, they're still getting fee for service for the most part and payments, but we know we need to be there in that risk type arrangements. We do have a life program, it's a PACE program, so it's a Medicare, Medicaid capitated program, so we have about 200 lives in that right now. So that's our one true risk arrangement we have, but we do see us going out and having to do some risk contracting in the near future. So trying to justify all these capabilities of the population health tools that you need to be able to manage these risk populations, that's a lot of cash outlay with no financial upside yet. We're banking on the fact that we can bend that cost curve. So there's a lot of good faith going on between the finance department and IT and the care management team here.
Yeah, and that goes into the whole issue of moving from a fee-for-service world to an accountable care world, getting ahead of the reimbursement changes to where you're keeping people out of the hospital and it's not creating more revenue, it's creating less revenue. So what are your thoughts about positioning yourself and moving towards the future when the revenue model isn't there yet?
So that is a challenge for us right now. I mean, we're trying to do that. We do not, like I said, we don't really have any risk arrangements at this point in time, so we're dabbling in some of those ACO activities like PCMH, which is more of a gain-sharing type program, so there's not a lot of risk there. There's just upside if, in fact, we can do that well, we can get some money and we can share it with the docs. So most of the stuff that we're working on right now is more of what I would call a gain-sharing program rather than a risk model. But we will get there, and we will have the tools in place, and we are educating ourselves and getting experience with those tools so we can start identifying those high-risk patients and going after some of them and trying to more control that cost curve right now without having things imposed on us. So we're being very thoughtful about that.
Any thoughts on patient engagement on the cheap? If you're a hospital that's really cash-strapped, some of the low-cost ways to engage that you've discovered?
Well, again, I would hope even a low-cost budget, you'd have some kind of patient portal. The activities around getting people involved and getting some value into that patient portal, I think you can do some of that stuff in an inexpensive way to make that more interactive. Again, not just looking at results, but actually driving other information to there that's of value to the patient. So I do think there's a lot of opportunities, a lot of products out there, a lot of companies out there that offer a lot of solutions that are inexpensive and can tie right into your personal health record strategy or your patient portal strategy. And that's definitely something that you should be pursuing.
Excellent. Excellent presentation, Tom. Thank you for the Q&A. That's about all the time we had for today. So again, I want to thank Tom Pacek. You will receive an email when our archive is ready. Separate registration is required. If you have the CHIME CHCIO certification, attending our webinars gets you 1 CEU, so go ahead and let CHIME know unless you've asked us to, and we will. Sponsorship opportunities for webinars, contact Nancy Wilcox. Any general questions, comments, you can contact me, and you can go to our site to view our upcoming schedule in the last 12 months of archived events. So with that, I again want to thank Tom and thank our audience, and everybody have a wonderful day.